Welcome, dear audience, to this webinar series the European Observatory on Health Systems and Policies is hosting together with the European Public Health Association as part of European Public Health Week, which kicks off today. My name is Deepa Rajan. I'll be moderating today's webinar on primary healthcare and resilience together with my observatory colleague, Erica Richardson. And we also have the honor of the presence of Tit Albrecht, the president of the European Public Health Association, who will provide closing remarks at the end. So today we'll unpack the contribution, the huge and critical contribution of primary healthcare on the resilience of the system. Our keynote speaker, Dion Kringos, will talk you, the audience, through three key features of primary healthcare, which lends resilience to the health system. And those are, and if there's only three things that you take away from this webinar, this is what it should be. Those three things are the proximity of communities to primary healthcare, or the other way around, the proximity of PHC to communities. Second, multidisciplinary team as a structure for primary healthcare. And third, the fact that good and strong primary healthcare integrates the population health perspective with the episodic curative individual perspective into primary healthcare services. But before I introduce Dion, I'd like to highlight a EuroHealth article which expands on this as well. My colleagues will put the link in the chat box now for those who are interested. And in addition, the observatory did a publication with the WHO European Centre on Primary Healthcare and with WHO headquarters a couple of years ago called the Primary Healthcare Primer. And there's a chapter in that, chapter 16, which lays out the literature on this topic of primary healthcare and resilience. And so you'll also find that link in the chat box. So allow me now to introduce our keynote speaker, Dion Kringos. She's head of the WHO Collaborating Center for Quality and Equity in Primary Healthcare Systems and Associate Professor of Health Systems and Services Research at Amsterdam University Medical Center. And she's someone that we at the Observatory have been collaborating with for years, notably recently on the Primary Healthcare Primer, where she's a co-editor. So over to you, Dion.
Thank you so much, Deepa. Good afternoon, everyone. It is a pleasure to present a brief overview of the evidence that positions primary healthcare not only as a pillar of universal health coverage, but as the cornerstone of resilient health systems. This presentation is based on the recent work that Deepa just mentioned, so on the European Observatories and WHO's primer on implementing the primary healthcare approach, and also on the recent EuroHealth publication that was just put in the chat. So next slide, please. Let's begin with clarifying what we mean by primary healthcare. Well, according to the Astana Declaration from 2018, primary healthcare is a whole of society approach to health. It aims to maximize health equity and well-being, responding to people's needs as early as possible along the entire continuum of care, ranging from health promotion to disease prevention to palliative care, and always as close as possible to people's daily environments. This definition positions primary healthcare not just as a service level, but as a philosophy of system design, one that emphasizes accessibility, continuity, coordination, and comprehensiveness of care. The strength of primary healthcare lies in its structural foundation, anchored in three essential components. Firstly, integrated care delivery that brings together primary care and essential public health functions. Secondly, empowered individuals and communities who are partners in their own care and in shaping the system. And thirdly, multi-sectoral policy and action, which recognizes that health is determined by education, housing, environment, and economic policies. These pillars make primary healthcare not only service-oriented, but also strategic, capable of creating coherence between public health, clinical practice, and broader social systems. Next slide, please. So health system resilience, which we can define as the ability to anticipate, absorb, and recover from shocks, has become a central concern for policymakers. Primary healthcare contributes to resilience in three temporal phases. Firstly, before a crisis, primary healthcare supports health security by delivering prevention, early detection, and risk communication. Then during crisis, it is often the first and most frequent point of contact, managing community-based triage, reducing pressures on hospitals, and maintaining essential services. Afterwards, following a crisis, primary healthcare facilitates recovery, addresses backlogs, and helps the system to learn and adapt. For example, during the COVID-19 pandemic, countries with robust primary healthcare infrastructures reported less disruption in chronic care, fewer service gaps, and faster restoration of care continuity. Next slide, please. Community engagement is an essential function of primary healthcare and a key determinant of resilience. It builds bidirectional trust, enabling people to access care confidently and systems to better understand and respond to local needs. During COVID-19, engaged communities were instrumental in mitigating inequities. For instance, in Ireland, traveled organizations worked with local primary healthcare providers to support vulnerable families, disseminate public health information, and co-design culturally appropriate vaccination strategies. Yet many systems struggle to incorporate community voices into formal decision-making processes. True resilience requires ongoing structured collaboration with civil society, not just in emergencies, but in routine governance. Next slide, please. Primary healthcare's multidisciplinary nature is a core feature of its adaptability and strength. Teams composed of general practitioners, nurses, mental health professionals, pharmacists, and for instance, social workers and community health workers offer integrated, person-centered and population-responsive care. For instance, in Austria, primary healthcare units manage dual-track pathways for COVID-positive and COVID-negative patients, ensuring that chronic care and prevention services continued. In Iceland, team-based care enabled rapid outreach in rural and high-risk groups, building on trusted relationship and local knowledge. Such teams do not just deliver services, they embody the flexibility and depth needed to sustain care during stress and crisis. Next slide, please. Another dimension of resilience is the integration between primary care and public health. This alignment enables primary health care to contribute to surveillance, contact tracing, outbreak response, and vaccination, while public health can inform primary health care with population data, risk analysis, and policy guidance. However, this integration is often underdeveloped. Where it was present during the pandemic, as in Spain, India, and Vietnam, primary healthcare providers helped implement and monitor public health interventions effectively. Bridging these domains ensures synergy between individual and population health services and increases a system's capacity to respond to both acute threats and chronic challenges. Next slide, please. A resilient system must also be a learning system. During COVID-19, primary healthcare demonstrated remarkable capacity for adaptation. Within weeks, services transformed to digital delivery through teleconsultations, e-prescriptions, and remote monitoring. In the EU, more than 40% of patients received care online or by phone. However, the rapid expansion of virtual care revealed equity gaps, digital literacy challenges, and infrastructure limitations. The lesson here is not that primary care was flawless, but that it is a testing ground for innovation and a critical source of insights to system-wide learning and reform. Next slide, please. So to conclude with this very rapid overview of the key evidence, we can say that primary healthcare is a central mechanism for resilience, offering continuity, accessibility, community linkage, and a learning capacity. Its potential, however, cannot be realized without deliberate investment, political prioritization, and structural alignment. To future-proof our systems against shocks, whether it may be pandemics, climate events, or social disruptions, we must ensure that primary healthcare is not marginalized, but empowered to lead. The evidence is clear. Strong primary healthcare means strong systems for today and for whatever comes next. Thank you very much.
Thank you, Dion, for that very quick overview. And I hope dear audience, that you're able to see how the key features of primary healthcare, which granted are not in all countries as strong as they should be, but when they are, they can really lend resilience to the health system. And ultimately, it's really about the fact that communities and primary healthcare is at that interface between communities and the health system. And the stronger that interface is, the stronger that glue is, and those links are and can be made, the more resilient the health system becomes, with primary healthcare really at its core and as its foundation. And that's why the community engagement piece is so important, that community proximity, but then also the multidisciplinary teams that also allow more community engagement as well, because of the community facing roles, and integrating those insights through the community engagement into the clinical care through the teams, through the communication between the team-based role, the community facing roles, and those in the team who do clinical care. And of course, this is ultimately about that integration of public health and primary care into good, strong primary health care. So I did mention that it's not as strong as could be in a lot of countries, which is why there's been a lot of support provided by the European Union, European Commission, to many member states in this region to strengthen their primary healthcare systems, especially following the COVID crisis. So we'll hear more about that from our next speaker, who is from the European Commission's Reform and Investment Task Force, which provided funding through various instruments like the RRF, the Resilience and Reform Fund, and through the TSI, the Technical Support Instrument for this area of work. So we're going to hear now from Simon Drees, who's a policy officer at the Secretariat General for Structural Reform Support of the European Commission, otherwise known as SG Reform. And he's worked in many other positions within the Commission, with DG Santé, DG Research, with ECHO, Horizon Europe Mission on Cancer. You're an old hand at the Commission, Simon. Let's now hear from the reform perspective. Over to you.
Thank you very much, Deepa. Thanks for the invitation. So yes, indeed, I wanted to start by just setting out what the rationale is for supporting primary care reforms. I think it's clear that there are kind of three main axes. I mean, one thing is that, as John has shown, that it's a critical element for the resilience of health systems. It's also, of course, critical for universal health coverage in our health systems. And then I think, as we see increasing fiscal pressures, there's also a fiscal sustainability argument, of course, to shifting care away from more acute treatment, in-hospital treatment, towards the primary care sector. What we do here in sectoral reform, in the Reform and Investment Task Force, which is a fairly new department, is that that kind of merges two previous departments that are working on the reform, on the Recovery and Resilience Facility and on the Technical Support Instrument, respectively. And this department that was only created on the 1st of February as a merger now integrates these two different instruments. And through both instruments, there has been a lot of emphasis on primary care reforms. As you know, the Recovery and Resilience Facility was mainly created as part of Next Generation EU to support member states in the recovery after the COVID-19 pandemic. And the Technical Support Instrument already existed before and is a demand-driven instrument to support member states with structural reforms across all policy areas. But here I work specifically on health system reforms. And of course, it's important to start by saying that we do this all in very close collaboration with the other Commission departments. And I want to specifically highlight the work of DG Santé, of course, in this area, both, for example, the expert group on health system performance assessment, but also through the joint actions, such as the CIS joint action on transfer of good practices in primary care. And this work is always our starting point, and we work very closely with those colleagues. Under the two instruments, we have a really, as I said, strong demand for health system reforms. Under the Recovery and Resilience Facility as a whole, we have over 44 billion euros in health system reforms. And of that, 16 billion euros are in the area of primary care and prevention. That's important to stress. So it's not just kind of core primary care, but as we have just seen, this link with public health functions is critical. And that funding has gone to investments in new primary care centers, in mobile pharmacies, in addressing specific geographical coverage problems, so addressing medical deserts and other things. But of course, in the Recovery and Resilience Facility, there's also a reform element And I just want to highlight that there are a number of countries really where we have seen reforms such as Ireland, Greece, Estonia, Spain, Portugal, Slovakia, Austria, and many of these countries were previously or at the same time supported under the technical support instrument. So for example, in Austria, we had already been working since 2017 on integrated primary healthcare centers that where we have multidisciplinary teams working in an integrated way. And this concept was kind of piloted, and the first units were supported with this technical support instrument projects. And then now there's a big reform and investment package of 100 million euros in the Recovery and Resilience Facility to further roll out this reform at the national level. And this is actually a pattern. So in Estonia, we have also worked on increased networking between primary care and the social care sector. And again, there's an investment and reform part of the Recovery and Resilience Plan in that country. So you see that really for these instruments that are really driven by the countries, there is a strong emphasis on primary care, a strong interest. There's also a core element which for us, which are the country-specific recommendations under the European semester, where also a number of countries have recommendations in the area of primary care, and both of the instruments that I mentioned are kind of centered around the country-specific recommendations. So this is an important criterion for us when we evaluate applications for support. And it was also a core element of the Recovery and Resilience Facility to address the country-specific recommendations. I want to close just by highlighting that we have continued interest under the TSI. We have a new project in Portugal. Portugal has a reform to introduce local health units which integrate primary care and secondary and also tertiary care at kind of regional local level. So in a total of 38 units across the country. And we are supporting this together with the WHO, this reform. And as part of that, we have a new community of practice of the countries that have been working on these reforms in the primary care area. And we are very happy to be working here also with the observatory very closely on kind of drawing out the lessons learned from these reforms and supporting countries that have benefited from our support in the past. And I hope that at some point we can then also share with a wider audience the outputs of that work. So thank you very much for the opportunity to be here, and I hand it back to you, Deepa.
Thank you so much, Simon, for highlighting the importance of primary healthcare for the Commission and also the importance of primary healthcare for resilience. And all of these countries like Austria, like Portugal, Austria with the primary healthcare units, Portugal with the local health unit, these are all reform processes that really just started mostly or intensified at least post-COVID in the quest to increase resilience of the system. So we see that there's a great demand for this. And it really at the core, if we want to strengthen, if we want to move towards more resilience of our system, we need to strengthen primary healthcare. So on that note, we are going to hear from a country-based speaker who's from Slovenia. And so that leads me to Urška Erklavec, who is the head of the Office for NGO Cooperation at the National Institute of Public Health in Slovenia. Urška, your country has been a keen recipient of RRF, Recovery and Resilience Facility, and TSI monies to support various reform processes and especially to support strong public health and prevention, as Simon so rightly highlighted, and to support community care. So tell us about these in practice and how they've strengthened PHC and in Slovenia. And then if you could spare a few words also on your role as the head of NGO cooperation and how that aspect of NGO cooperation has really contributed to health systems resilience and PHC strengthening. And on that note, I'd also like to highlight before I hand over to you that to our audience that Urška actually straddles the government and civil society perspectives with her background. Before coming into her current role, she was at the Slovenian Ministry of Health. She supported the Slovenian EU presidency. And before that, she was president of the youth organization No Excuse Slovenia and has been quoted as saying that she's ultimately a public health activist by heart. So over to you, Urška.
Thank you, Deepa, for a very nice introduction. And thank you for the opportunity to speak today. In Slovenia, we have already a century-long tradition of collaboration between primary healthcare and public health. and that makes Slovenia quite unique in this perspective. Our innovation journey, if I can call it like that, in primary healthcare began over 20 years ago. In 2002, when we launched health promotion and prevention activities in our local community health centers. And these programs were targeting key risk factors for non-communicable diseases. And we were combining population level strategies with individual support, like offering thematic workshops, one-on-one counseling, all to help people manage or prevent different chronic conditions. And after a decade, when we evaluated these programs, the results quite surprised us. Despite being free, they weren't reaching many of the vulnerable groups. Some people didn't know the services existed, others didn't really feel they were for them, and that was a turning point. So when new funding opportunities came along, like the Norwegian financial mechanism, EU cohesion funds, later also, as mentioned, EU's Recovery and Resilience Facility, we asked ourselves a new question: how do we meet people where they are through those that they already trust? So in 2014, when we started to upgrade our health promotion centers, we added a bit more structure, more services, expanded also our multidisciplinary teams. So from community nurses, we also added dietitians, kinesiologists, psychologists. And with the RRF, we've gone also further. We're now integrating geriatric care, expanding mental health services, modernizing musculoskeletal care, investing in digital transformation, all within primary care. But we know also for many years that service improvements aren't enough alone. And that's why we also took a step further into the community, as I said, to meet people where they are through those they already trust. And that's why we're connecting our centers for health education and promotion with local NGOs, with schools, social services. We wanted to stop working for communities, and we're starting to work with them. That's why we're co-financing NGOs for already many years, including patient organizations, different youth organizations, volunteers, civil protection teams also. And this was not enough to build enough more cooperation between health system and civil society organizations. And let me be honest, not everyone in the health system is ready to trust to make this step. This has to be built carefully, intentionally, over time. So now we're creating different mechanisms for partnerships, not just for consultation, but focusing on a true co-creation. And we know this couldn't be the side project of a few passionate individuals. It needs structure. And that's why in last year, we established this dedicated service for NGO cooperation, the National Institute of Public Health. And it's not just as a bridge to the health system, it's also like a platform for social participation, for cross-sector collaboration, intergenerational learning. And I can also say that our health literacy remains one of our biggest challenges, and of course also one of our greatest opportunities. And by working with civil society, we're not just sharing information, we're trying to empower communities to become also advocates themselves across generations in the places where they live and also where they work. And this is, I think, what makes Slovenia's story not just a reform. We could say it's like a story of transformation. Of course, it's not perfect, it's not finished, but we're trying to ground it in trust and I think we're growing stronger every day. I wanted to end a bit with something personal, how I started as a teenager in a youth organization, but Deepa already very nicely introduced how I then through my journey went to the Ministry of Health and now to the National Institute. And I've seen how powerful it is from firsthand when the civil society moves from the outside to become a valuable partner in this journey. And you also begin to understand not just the limits of what one individual or one organization or what one sector can do alone, but you also start to understand the real power of relationships and how trust is essential when you're trying to improve the health of a population or even just one person. Thank you for listening.
Thank you so much, Urshka. And I think trust is really at the heart of resilience as well. That trust that we need to foster between people and the health system, between communities and the health system. And I'd like to just highlight something that Urshka said. So she talked about the emphasis on public health and prevention that the Slovenian Ministry of Health and other health institutions really put, and at the same time, that community engagement piece. And I think really to make that work, to really do good prevention and good community engagement, you need those multidisciplinary teams. So that's that third pillar for contributing to resilience, for PHC's contribution to resilience, because it's within that team. We know that the GP can't do everything, that it's within that team that you have different roles, including community-facing roles, including more public health roles, whereas the GPs, obviously, their core role is really around their value add and their training, which is that complex care for chronic patients, really. So we're going to now hear from our next speaker. We're going to hear from patients. So we're going to hear from Flavia Topan, who is head of communications at the European Patients Forum since 2022. And before joining the EPF, Flavia handled communications and PR activities for both public and private hospitals in Romania, and worked very closely with national patients associations and patient education projects. So this is really your professional journey and path, which is all about patients. So give us the patient perspective on all of this. Over to you, Flavia.
Hello, everyone, and thank you very much for this invitation. I'm very happy to be here today and to bring the patient perspective to this topic. And I'm also very happy that the speakers before me actually mentioned some key components and some key elements that you will also see in my intervention today, such as community engagement, patient engagement, health literacy, and so on. But maybe to start, when I was preparing for this panel, actually, I remembered an experience I had several years ago while I was teaching a communication course for GPs in rural Romania. And one of them shared something to the group and with me that kind of stuck with me ever since. He said that I've been someone's GP from the time I gave their first vaccines in infancy all the way to signing their medical certificate for marriage. Now, to me, this really captures the essence of continuity of care, to actually walk alongside someone through all the stages of their life. And I think this is the kind of relationship that builds trust, strengthens resilience, and actually makes health system truly work for people. Now, at the European Patients Forum, we see primary care beyond being the first point of contact, but as the foundation of resilient health systems. Because when we talk about resilience, oftentimes, we focus on budgets, hospital beds, workforce numbers, which are, of course, valid and very important factors. However, resilience, at its core represents a system's ability to absorb and to withstand shocks. Unfortunately, the COVID-19 pandemic showed us how highly centralized health systems just collapsed under pressure. And by contrast, resilience lied in decentralized, community-driven systems that could adapt and respond locally. So primary care in this context can serve as a network of resilience nodes, able to detect early signs and tailor intervention to fit the local realities, I would say, which obviously allows for faster responses and more sustainable, culturally mindful care, I would say. For patients with chronic conditions, the quality of their care journey and consequently the quality of their life relies on what happens at primary level. Yet somehow health systems remain largely oriented towards acute care rather than long-term support for chronic patients. Something we hear often from our member organizations is that they feel they have to kind of fight the system to access care. So from a patient perspective, access is quite a mosaic. Can I find care? Can I afford it? Do I understand it? And do I trust the people who deliver it? So we believe resilience also depends on how well care is connected and how well patient pathways are supported. And this is where health literacy actually comes in, because at EPF, we believe that all patients, regardless of their background, have the right to clear, accessible information about their health and available treatment options. And also organizations like EPF play a central role here, because we can create materials that are trustworthy, relatable, relevant. As such, patient organizations should be recognized as strategic partners in supporting informed decision-making, which leads me to community engagement. And as Dion mentioned in her intervention, this is key in delivering primary care. And the core of it is trust, and trust is built through a genuine patient and community involvement. At the point of care, this translates to better adherence to treatment, for instance, but at policy level, involving patients helps identify potential gaps and shape practical people-centered solutions. But for this to happen, we need communication and partnerships. This should be core competencies for primary care professionals, not just only afterthoughts. And crucially, we must acknowledge that goodwill alone is not enough. No one can deliver person-centered care while facing staff shortages, burnout, or lack of time, which means that also investing in primary care means investing in the conditions that allow healthcare workers to care properly. So to summarize, for patients, I believe resilience is built on continuum of care that supports people throughout their life and their care journey, from early prevention to long-term disease management. It is sustained by health literacy and by shared decision-making that builds trust and partnerships between patients and professionals. And as a concluding thought, I like to say that, storms will come either way. And I think in healthcare, resilience is not about weathering storms, but rather about setting up the structures that don't collapse in the first place. So thank you.
Thank you, Flavia. Yes, it's about setting up the structures that don't collapse in the first place. And those structures means that a very strong link between health systems and the people the health systems are supposed to serve. And I liked the fact that you really highlighted health literacy, because really that link is, and good community engagement is not only about policymakers or the health professionals engaging with communities, but communities being empowered to engage and having the capacity to engage, which is not always that easy, because often they're in civil society organizations, these are volunteers, communities have a different language. And so a system that supports communities and civil societies in their health literacy, to strengthen their health literacy, is gains in terms of contributing to a strong health system and to resilience. So it's a win-win there. So we've heard a lot from our different speakers. I see that our chat box has been very active. We'll move to a round of questions, and I will call on my colleague Erica to tell us a little bit about the discussions in the chat box, the topics highlighted, and maybe put through a couple of questions for our speakers. And if I could have all of our speakers go on video. They can then answer those questions. Go ahead, Erica.
Thank you very much, Deepa. Yes, nice lively chat box. Thank you to everyone. And greetings to all the nurses in the room. Happy International Nursing Day. So yes, that had slipped my mind. So I'm very, very grateful to the people in the chat box that pointed that out. And in honor of that, I think we should start by with a question of how we addressed resistance from dominant healthcare professions. I think we mean doctors there, to the boundary work of task shifting. So how do we get nurses and allied professionals into decision making about strengthening the resilience of primary care? And quite a basic question on who should be in a multidisciplinary team. Do we have an ideal view of who should be in a multidisciplinary team? And the big question, how do you take money away from acute care or hospital care to finance primary care in systems which are very heavily oriented towards secondary and tertiary? So yes, over to you. I'll now gather another round of questions.
Is there anybody from the panel who'd like to volunteer to take any one of those 3 questions? Go ahead, please, Diana.
Well, on the topic of task shifting, I think we need to focus on 3 strategies to get to overcome the resistance of health professionals. I think first, an evidence-based dialogue could be helpful, like we're doing today, that would demonstrate on how task shifting improves access, efficiency, and patient outcomes without actually compromising quality of care, which might be the fear of certain professionals. I think secondly, inclusive change management is needed that involves those professions in the design and implementation of boundaries of work to help them to see the value of task shifting and not seeing as a threat, but actually as a kind of evolution of collaborative practice. And thirdly, I think, is touching on recognition and incentives, that we acknowledge the professional contributions that provide support, for instance, through training and career development, which could actually reduce perceived losses of control of status. So I think 3 strategies would be needed to overcome the resistance against task shifting.
Okay, those are 3 clear strategies, and I think that's what the direction that we're going towards. It's not an easy path, but I think and sometimes it's 1 step forward, 2 steps back, but we need to keep trying, I think, to go that direction and come together on the same page. I'm looking at Urška, Flavia, Simon, any other? Flavia, go ahead.
I was thinking while Dion was answering that I think this is one of those cases where there is no one solution fits all, which is why community involvement is so important, and just, I would say, local somehow interventions. And I also think change management is an important process of all of this. And on top of that, I would say just continuous education. So maybe the generations that are now are more reluctant, but if education starts very early on in like medical education, for instance, then this flexibility and capacity to adapt to changes might have a different outcome in a couple of years.
Absolutely. I mean, medical education is at its at the heart of that. It's also linked to change management, because a lot of the issues that we have in moving towards a new way of working is the fact that I think those who are more trained in curative or specialist care have a completely different mindset than those who think of who look at the health system more from the population health perspective, community care perspective, and those are paradigms that are clashing, and you need really good change management interventions to really bring that together. And that's also something that we found in the evidence reviews that we did for the PHC primer. Would anyone like to take the question on the ideal multidisciplinary team composition, or the financing question in health systems where we see across Europe, even still today, where we have all this evidence on primary healthcare, where the vast majority of the funds of health budgets actually do not go to primary healthcare?
I can go
Urška?
ahead. Yeah. So I would maybe link it with what was already answered, that I think what we have kind of the advantage now that we already have some front runners, so some countries that have already successfully implemented that. And through like events like that and networks that we have at the European level and global level, we are able to learn from each other and also see all the good benefits that these innovations already had in other countries. And I think the other one is like opportunities like cohesion funds and now RRF are kind of windows of opportunity where the country can try to pilot some of these innovations into their system. And once people in the primary healthcare see that all the benefits that they can get from these innovations, they also become the advocates themselves, because many people in health system already see that the needs of people are much more than that current capacities of in kind of like HR capacities of the health system can cover, and that's why also the multidisciplinary teams can come in to supplement all these needs. And on the financial, I think, yeah, when these systems get running and the people see all the perks of that, we also then have the, for example, in the case of Slovenia, we have the Slovenian insurance funds that cover then the services that are structured in the way that that they also finance all this additional services that we've been talking about.
Okay, thank you, Urška. So yes, EU funding to help pilot and to help the population and policymakers see the benefit might catalyze other types of funding, insurance level or national level funding. That's an interesting thought, but I think one that hasn't escaped the European Commission's reflection process. Shall we go to another round of questions, or did anyone from the panel still want to comment on this round of questions? Simon, please.
Yeah, just very briefly, I think financial incentives are absolutely critical. And I think what is important there is really the clarity, right? I mean, we often see that, you know, there are minor changes that are made somewhere. I think it's very important to have clarity in the financial incentives to the health professionals. What does the reform change mean for them practically? And also that the incentive really can kind of take its effect, right? Because if you don't really feel it, then you know, it's not going to have a practical impact. So I think that's important. On the composition of the teams, I think my sense is that there is no ideal answer, but I don't know if Dion has a different answer there. But I think what is important for us in the projects that we do is really step one is to agree on definitions. I remember I was last year in Estonia, we were working on a project there, and step one was to agree what do we define as primary care for the purposes of this project, right? And I mean, yes, we have a lot of international definitions and literature, but I think this is really important. What is the scope that we are working on in this project? And I think that should really be step one. And we need to be very context specific, because we have, for example, I mean, in some countries we have GPs, in others we have family doctors, we have different roles of pharmacists, for example, what is their role in service provision. So this is for us always the first baseline to fully understand the situation. And if I may, I see this question on telemedicine in the chat. I mean, this is one thing that is really important, of course, telemedicine. I think especially when we talk about member states where we have large rural areas where we don't have the professionals anymore. We see the decline in GPs across many countries in the EU. But what we find there is that we really need to look at the digital skills of the patients, but also of the professionals. And we can't just, you know, hope that technology will solve it all, but there are kind of inherent implementation challenges with those solutions as well that need to be tackled. And we had a whole flagship on digital skills where we focused on training packages for professionals to use electronic health records to basically become more agile and more flexible in deploying these solutions. And I think that should always come hand in hand with the introduction of things like telemedicine.
Yes, absolutely. And I think that is really also the future of primary healthcare. Dion, please.
Yeah, I just wanted to add on Simon's remark on the composition, the ideal composition of multidisciplinary teams. I think in the end, the exact mix that is right for a certain context depends on the local health needs. So that should be the main driver, the local health needs and the context, of course. But we know from research that in general, strong primary health care teams. They consist of GPs, nurses, mental health professionals, social workers, and allied health staff, such as physiotherapists, dietitians, and then supported with community health workers and admin staff. So that we know from research that's on average a successful primary health team, but leading should be really the local health needs.
Yeah, great. And one sees really in that composition that, we have we have those that are more community facing, like the social health workers, like the community health workers, and we have, we have those that are really focused more on the episodic curative care, and then all of the allied health professionals, which support with their expertise and basically take away the burden from the GP to be doing everything. So it really links all of the different aspects together that also make PHC strong and hence lend resilience to the system. Erica, do we have time for maybe one or two more questions? How are we placed?
Oh, we've definitely got time. We've definitely got time. I'll just so we've got some quick fire ones. If anybody else wanted to jump in on digital tools and what they see as the role in primary care for digital tools in strengthening resilience, that would be great. Grand. Otherwise, what can we do about health workforce shortages and what they mean for primary care, primary healthcare resilience? And how do we measure the resilience of primary healthcare, particularly things that are quite sort of nebulous, like community engagement? How do we measure that and the effectiveness of that? And in fact, do we even need to measure it? Maybe there are some things that don't need to be measured. And maybe this is one for Flavia, but managing patient expectations in multidisciplinary teams. When people expect to see a doctor and you might want to refer them to another member of your team, how do we manage patient expectations? So back to you, Deepa.
I'm looking at the panel who'd like to start. Pick your question, and then we'll move on to the next.
Yeah, I can take over the patient expectation part. A big part of the work we do here at EPF is this health education, health literacy, and actually empowering our communities to become advocates themselves and to raise awareness on certain topics. For instance, one of our most recent projects is, or focuses, I would rather say, is on antimicrobial resistance and chronic patients. So it is true that a big part of navigating the system means knowing who to ask and where to go to. And I think this is where patient organizations such as EPF can step in. This is an example I often give. In one of our projects we ran during the pandemic, there was a study on vaccine hesitancy in several countries in the European Union, and the results showed that especially in countries where people are not that, where trust levels of the populations are low and centralized in governments or in politicians, etc., they do tend to turn to patient organizations, civil society, and general practitioners. So I think this is a very, very important tool we could have for education and for managing expectations, as you said. And in terms of quantification, I don't think I think it's a longer term process, and the results will not come overnight, but then at some point you will see a decrease in patients seeking acute care when it could be handled by a general practitioner.
Okay, thanks, Flavia. Yes, and on that topic of measuring community engagement? I mean, this is a bit of a difficult one. I don't know if Ushka, you have thoughts on that. We recently had the WHO resolution on social participation, which calls on WHO to put out a monitoring and evaluation framework to better measure it, because we know that we don't measure it at all or well enough. Any thoughts on that and what might be done in Slovenia on it?
Yeah, thank you. Yeah, it's indeed quite a challenging question how to set up the right system to evaluate, because on one side we're evaluating like kind of the amount of the community engagement that's happening, but also the quality, because sometimes it's not just about the quantity, but it's mostly about the quality of engagement and working together. And there are different nuances. But I can also comment like a bit on the our primary healthcare system, how community centers are working, because each team to kind of ensure equality or kind of comparedness between different community centers. They have like key targets of like different kind of community events that they have to reach, or different workshops or levels of engagement that they need to ensure. So this was kind of a bit more rigid system to ensure that there is comparability, to ensure that they get financing for their working. So this is then more on a technical note, how to ensure this engagement happens. But yeah, I think this is something that will be kind of a hot debate also in this upcoming years, how to ensure this is done in the right way.
Yes, absolutely. And as you say, it's what often gets measured is whether it's happening, if these events are happening, if a community member, civil society member, or organization representative was sitting in a meeting. So it's whether it happens rather than the quality of it. And the quality is a little bit more difficult to tease out. We have maybe time for maybe one response if somebody wants to take the question on health workforce shortages and within the context of strengthening primary healthcare and resilience. Diana, please.
Yeah, on the shortages of healthcare workers, I think we need to invest firstly on training a broad range of primary healthcare members, and not just the GPs, but also the nurses, the health community workers, physician assistants, and different allied professionals. So that they are equipped to take on additional roles through task sharing. I think secondly, we need to invest in retention to make sure that those who are active and contributing within primary care stay there. Also expand task sharing across team members, as we have been discussing. We've also been discussing the role of telemedicine and use of digital tools, for instance, to reduce admin burden, but also invest in improving the attractiveness of the working conditions in primary healthcare, especially in underserved areas. I think those will all be helpful in overcoming shortages.
Yes, so also very clear strategies, Dion. Thank you. Not always so easy to implement in practice, we know, but we do have the solutions. But we need to work through some of those implementation issues and learn from each other as we do so. I see that we are now at the time where we would like to hear from our president of EUPHA, of the European Public Health Association, to provide some closing remarks. Tit Albrecht, if you can come online.
Hello, everyone. It's a pleasure and an honor to be invited to this, to comment on today's webinar, which has provided for a lot of confirmation for many of us, and a lot of food for thought for the broader health policy, but also public health community. I will start by saying that unfortunately, some of the events in the near past that have already been addressed by the speakers, such as the pandemic, have pointed out that even very high income and very high resourced areas in principle may succumb to the crisis when not adequately prepared, adequately resourced, and adequately organized to face a challenge such as the pandemic. This means that, of course, primary healthcare is a as an important but at the same time, a very fragile part of our system. I will pick up on several important points presented by the presenters. And I will start with something that used to be dominant in the clinical discussions, but was strongly underlined by the speakers today. And that is the multidisciplinarity of primary care. Of course, multidisciplinarity in primary care means something different than in the clinical setting. We bring to the table different professionals that go beyond the clinical excellence or the subspecialties involved or that have to be involved in the management of the patient. We bring social workers, psychologists, we bring sometimes rehabilitation specialists, sometimes even people who can help patient reintegrate in the process after having had the experience of a chronic disease. This means that we have to build on supporting the work of the core team that usually addresses the patients with other professionals. This has to become a practice. Failure to do so will lead to the negation of another principle we often defend, and that has also been strongly presented, especially by Flavia, the patient centricity. If the patient is in the center of our attention, we have to follow their needs. Their needs are not only acute. They started before a disease had started. This was very nicely illustrated by Flavia's story of a GP that follows someone from birth to marriage and beyond, but also after the acute experience. And sometimes, very often actually, the primary care teams have to support the patient in struggling to return to the pre-morbid life or to live with a disease that has just been diagnosed. On digital tools, I'm very much in favor of supporting with digital means both professionals as well as equipped patients. But we cannot, on the one hand, stress the importance of health literacy and recognize the gaps in health literacy across the population and try to enforce tools that might alienate an important part of those same patients. So we have to be flexible and we cannot be too demanding on our patient population. And I can quote one of the patient representatives from a meeting I have attended recently. Eventually, people want a face-to-face contact because it's still more personal, it's still more natural to them. Let's not forget the personal contact. And a team, a multidisciplinary team at primary care might seek to accommodate those needs. Finally, human resources in primary care. In the monetary sense, primary care is never as attractive as many clinical disciplines, not only for medical professionals, but even for some others. We have to realize that, and we have to support health professionals willing to work in these settings in various ways. And this cannot be only the task of the local community where these teams and these structures are strongly based in, but also of those who design the health systems. And this is my final remark. It is very great that the European Commission has recognized the importance of primary care and has even supported the activities of many member states in strengthening primary care through various types of projects under DG reform. I think this gives it a special overarching flavor and supports the initiatives and enhances also intra-country, inter-country, and EU-wide collaborations. Thank you very much for your attention.
Thank you, Tit, for wrapping up for us on the importance of primary healthcare in resilience. Thank you, dear audience, for listening in. As I said, this was the first in a series of 3 webinars for Public Health Week. The next one is tomorrow at 12 noon CET, and it will be on resilience testing, entitled Ready or Not, Lessons from a Global Review of Health Systems Resilience, which we have done here at the Observatory. So we hope to see you then, and have a good afternoon. Bye-bye.